the responses. Well, joining us on the program in Lagos is Dr. Ladapo Ashinobi. He is a public health physician. Thank you for joining us.
Thank you for having me.
All right. First, I'd like to get your thoughts. The cases Lagos yesterday. I mean, it was really surprising, 356 cases. What's your take on our efforts to sort of prevent a third wave, or are we pretty much in the middle of that wave?
Well, if we go back to the last community survey done by NCDC in Lagos, that was almost 6 or 7 or 8 months ago, thereabout. People's blood sample were taken. Nasal sample were taken, and then they wanted to know how common COVID would be in the whole of the country, in 4 states. Lagos happens to be one of them. And in that community survey, it showed that about 1 in 10 people had COVID. That's a 10%. So if you follow that trend, it won't be surprising that we're getting this. Why are we getting 350 or more people are testing? And it means we'll get many more cases. Why are many more people testing? Because there is higher need for testing now. This is the summer, so some people want to travel. Some people want to do new things. And so they have to take the test. And so if you have to take the test, they are likely going to get more positive cases. And are coupled with an increase in social interaction and disobedience to non-pharmaceutical intervention. So it's expected.
And the thing with testing is that, the rule for testing is essentially those who have the symptoms, and not necessarily, we don't do pool testing or...
No, this result will also include those who don't have symptoms that you need to travel. You don't need to have a symptom. It's a mandatory requirement for travel, right? So,
yes. So I'm sort of saying that it seems that even the cases we're getting out, people who are presenting themselves to test.
Yes.
What about those that perhaps cannot afford the test and
the test
are not
is
presenting
free
with symptoms,
country.
are asymptomatic, for example?
No, those who need the test in the country, that means those who are not traveling. The test is free.
Yes, but they may be asymptomatic.
It's still free.
So we're not doing we're not doing the massive testing that we need to be doing.
Yes, because people are not coming, not because the capacity is not there enough for now. And that's why I said those tests are free. So if it is free and many more people are not coming, as it was, let's say, sometime in July, August last year, June, July, August, then you're not likely going to get the numbers you expect. However, it's not surprising. Delta or no Delta, irrespective of that, the testing is not enough. We have not hit it. If the whole country was doing between, let's say, 1,000, between 300 to 500 a day minimum, then you will see what we will see, or 1,000 or 2,000. Then we can say, okay, maybe we are getting close. However, you can use this as a marker that, well, out of how many people who did test, how many came out positive. So that's the marker.
So when it comes to what is called global best practices for infectious diseases outbreak, how close is Nigeria to perhaps, a few countries?
We're not that far. Every country work within its resources, its policies, and within the context of its people. In the international realm, between countries, there's what is called the International Health Regulation. So what will make Nigerians understand it better is if you are leaving Nigeria for another country, you will say you want a yellow fever, yellow card. Then, so now COVID has taken over. There is now COVID passport, something. So you want to travel from Nigeria to another country. Have you been vaccinated? Or do you have COVID? So those are international coalition of how people move around. And it gives you what the international acceptable standards are. Now, that international health regulation is domesticated in Nigeria. So there is the in-country type of health regulation, which is called the Integrated Disease Surveillance and Response. Now, in this integrated disease surveillance and response, there's a structure from the local government to the state to the federal level where you have emergency preparedness committees, and then at the state you have emergency operations committee, and at the federal. So these committees are there. So meaning we would have 774 if they are all functioning, right? And so in this emergency prepared committee, you have a list of about 40 diseases. Okay, it has increased now because of COVID, monkeypox, and H5N1. Those ones were relatively new biosecurity threats in the last 7 years. So they've been added. So we'll be looking at about 45. So these diseases are tracked every day, every week, and every month. Now, if anyone spikes out of the regular occurrence that what you did not expect the last month or the last year, then it becomes an epidemic in that local community. And then immediately the rapid response team of that local government is activated. So since COVID, the rapid response team of the 774 local government remain on high alert. So if you hear, we think there is an increase in COVID cases in this community or in this school or in this church, the rapid response team moves in, investigate. They do surveillance. They assist in getting the cases investigated. They do follow-up. They do tracking. So all hospitals report these cases if they are occurring normally, right? But if you see these numbers are increasing beyond what we expect, then something swings in. It's already in a template. It's not new. However, what COVID has done, it has brought this public health response into a higher limelight.
All right. Well, I know you definitely join us again to talk more about infectious diseases, but we'd like to appreciate your time on the program. Thank you so much, Dr. Oladapo Ashinyobi, public health physician.
Good luck and stay safe, Nigerians.
You as well.